Thank you very much, Greg. Before I get into the substance of my talk, I do want to spend a couple of minutes telling you about some of the great events of NATF. We were founded back in 1986, and we are really coming into our own this year. Although we are the North American Thrombosis Forum, we've presented educational symposia this summer, both in Berlin and in Barcelona. So we are becoming international at the same time that we remain true to Canada, the US, and Mexico. We have two great events, both scheduled in the Joseph B. Martin Conference Center, where we are currently, that I wanted to tell you about in case you want to jot them down. The first one is on Wednesday evening, October 18. It's a celebration of gratitude and a fundraising dinner for NATF, where we're going to have an Olympic medalist talk about how she got a bronze medal in track, even though she had a pulmonary embolism and had to deal with all the emotional, psychological, and physical constraints of pulmonary embolism. So I hope you'll be able to come to this event, and our NATF staff at the registration desk can give you additional information. Then you received a brochure within today's program, and if you want to pull this out for a minute, on Saturday morning, December 2, we'll be once again here at the Joseph B. Martin Conference Center, and we're going to talk about prevention of DVT and pulmonary embolism, and also prevention of stroke in a dedicated program that I think you'll all find fascinating. We have the details of the lectures here. This will be an inaugural type of program. The price is going to be right for this, which I believe is going to be a price that is basically zero, and we'll serve breakfast, and it should be a very useful interactive session. So I hope you can put Saturday morning, December 2 on your calendar as well. Now, we're changing the way we look at venous thromboembolism, or VTE. We think it is primarily a chronic illness, which warrants consideration of extended duration anticoagulation. And there are certain guiding principles. We think that venous thromboembolism is mostly a chronic inflammatory disease, like myocardial infarction or diabetes, which we just learned about. And for the most part, and this will come as a surprise to some of you, we do not think that VTE is cured after 3 to 6 months of anticoagulation. Suppressed, possibly, but not cured. We think that in many instances, VTE lurks subclinically, waiting for the right opportunity to recur. We know for certain that VTE requires lifelong attention to risk factor reduction with heart-healthy lifestyles, such as good exercise and nutrition, and in many instances also with medication. Here we have an important study from Padua, Italy, that was carried out by Paolo Prandoni, looking at what happens to patients with pulmonary embolism, or DVT, after they have stopped their 3 to 6 months of anticoagulation. And what we see over the ensuing 10 years, not taking anticoagulation, that among those patients with an idiopathic or unprovoked VTE, one that really comes out of the blue, about 50%, 1 out of 2, will develop another DVT or another pulmonary embolism. And usually that second DVT is more severe than the first DVT, and that second pulmonary embolism is usually more severe than the first pulmonary embolism. But what about patients who have a secondary or provoked DVT or pulmonary embolism? After they stop anticoagulation, 10 years later, 20% of them, 1 out of 5, develops another DVT or pulmonary embolism. What could be the explanation for this high recurrence rate of DVT and pulmonary embolism? There can be persistent risk factors such as obesity, diabetes, metabolic syndrome, or a sedentary lifestyle. There can be persistent inflammation that can wax and wane in intensity, and we think that inflammation is often a root cause of pulmonary embolism or DVT. And there can be persistent hypercoagulability that is either genetic or acquired. And one example would be anticardiolipin antibody elevation or lupus anticoagulant syndrome. We're paying a lot more attention to a new host of risk factors for DVT and pulmonary embolism, and these risk factors are linked to inflammation. And here they are, some examples: pneumonia, inflammatory bowel disease, psoriasis, lupus, end-stage renal disease requiring hemodialysis, or the preservatives in blood transfusions. These are all inflammatory risk factors. Here you see patients with psoriasis compared to patients without psoriasis in terms of the cumulative incidence of pulmonary embolism and DVT over a 10 to 12-year time period. And what we find is those patients with underlying psoriasis have double the rate of developing pulmonary embolism and DVT compared to those patients without psoriasis. Even the use of antibiotics, and this antibiotic use is a surrogate for infection and inflammation, turns out to be a risk factor for VTE. And you can see that with antibiotic use, you have more than a double the chance of suffering DVT or pulmonary embolism, and a higher chance of a recurrent DVT or pulmonary embolism compared to no antibiotics. And actually, it's a 5-fold increase in suffering of first DVT or pulmonary embolism with antibiotic use compared to no antibiotics, and double the rate of recurrent DVT. It turns out that DVT and pulmonary embolism are not merely clusters of red blood cells that are clumped together. In the olden days, VTE used to be called a red clot disease, and myocardial infarction and stroke were called white clot diseases. That no longer is the case. Now we see with special staining where we have white blood cells, which are a sign of inflammation and infection, staining brown, and platelets, which have a lot of inflammatory mediators inside them, staining blue, that the pulmonary embolism and the DVT are a combination of red blood cells, white blood cells, and platelets. And the white blood cells and platelets accumulate because of inflammation. Let's look back at clinical trials that have randomized patients to long-term anticoagulation with warfarin, which is also called VKA, vitamin K antagonist, versus short-term anticoagulation with warfarin in more than 3,700 patients with DVT and pulmonary embolism. In those patients who were randomized to receive long-term anticoagulation with warfarin had 80% fewer recurrences of DVT or pulmonary embolism than those patients who were randomized to receive short-term anticoagulation. But there was, with warfarin, a penalty to be paid, a 3.4 times greater rate of major bleeding complications. Now in the era of the novel oral anticoagulants, where the rate of major bleeding complications is far lower, the benefit has increased for a more extended duration anticoagulation. And in the Einstein Choice trial, published this year in the New England Journal of Medicine, more than 3,300 patients who had already been treated with 6 to 12 months of anticoagulation to treat pulmonary embolism or DVT were randomized to rivaroxaban 20 milligrams a day or rivaroxaban 10 milligrams a day or low-dose aspirin, and they were followed for a year. And what was found, both in those patients with provoked pulmonary embolism and DVT and unprovoked pulmonary embolism and DVT, is that those patients treated with either of the two doses of rivaroxaban had a 70% reduction in new events compared to those patients who were treated with low-dose aspirin. Now, provoked VTE has traditionally only been treated previously with 3 to 6 months of anticoagulation, but the Einstein Choice study raises questions now of whether we should be giving these patients long-term anticoagulation. And it appears that there are some minor persistent risk factors that particularly predispose patients to recurrent VTE, including inflammatory bowel disease, lower limb paralysis, heart failure, obesity, a family history of venous thromboembolism, and a hereditary hypercoagulable state. In the Einstein Choice study, we see that both the 20 and 10 milligram dose of rivaroxaban reduced the rate of recurrent VTE by about 70% compared with low-dose aspirin. And in terms of the safety and the rate of major bleeding complications, in this large Einstein Choice study, there was no difference in major bleeding complications between low-dose aspirin or either of the two doses of rivaroxaban. Now, other novel oral anticoagulants have also shown great efficacy and safety. The Amplify study with apixaban to treat acute DVT or pulmonary embolism had a trend toward fewer recurrences during the first year of anticoagulation compared with warfarin, though this trend was not statistically significant. But there was a marked reduction in major bleeding complications during this year of therapy with apixaban. And then this apixaban was tested for long-term extended duration anticoagulation in another trial called Amplify Extension. In the Amplify extension trial, patients had already received 6 to 12 months of anticoagulation, and then they were randomized to a continued dose of apixaban or to placebo, and those patients who received either of the two doses of apixaban, either 2.5 milligrams twice a day or 5 milligrams twice a day, compared to placebo, had an 80% lower rate of VTE. As for safety, the apixaban 2.5 milligram twice daily dose had the same rate of major bleeding complications as placebo. Now, let's consider two cases, and I'm going to ask everybody whether or not you're a healthcare provider to vote. Please don't abstain. This is a 42-year-old man suffering symptomatic bilateral pulmonary embolism despite Lovenox prophylaxis on his third day of hospital stay after gastric bypass surgery. There's no past history or family history of pulmonary embolism or DVT. The hypercoagulability workup is negative, and the question for us to vote on is how long do we anticoagulate? And it's one of two choices. Choice A is 6 months or less, which would be the current guidelines, which do not take into account the Einstein choice study, which had patients with provoked venous thromboembolism. This is a provoked venous thromboembolism. And choice B would be for a greater duration than 6 months. So if you think this patient should be treated for 6 months or less, raise your hand. There has to be someone of the 200. Dr. Gabay, two of you, okay. Now, I hope we're not going to get any abstentions, but let's see. How many of you want to give this man more than 6 months of anticoagulation? Raise your hand. Okay, so by a margin of about 100 to 1, anticoagulation for an extended duration is chosen, even though the current guidelines don't reflect this. So I guess what we're saying is we think the guidelines need to be revised. But the situation might be a little more complex. Consider this patient. Patients like this, Dr. Piazza and I frequently see in our outpatient offices. This is a 23-year-old woman. She suffers also a symptomatic bilateral pulmonary embolism 8 months after starting a third-generation estrogen-containing birth control pill. That type of birth control pill, by the way, has the highest rate of pulmonary embolism and DVT, but it also has some other effects that are quite popular, such as it decreases hirsutism and it decreases acne. So she had no past history or family history of pulmonary embolism or DVT. Her hypercoagulability workup is negative. Now, she's only 23 years old. How long do we treat her? Choice A is 6 months or less, and choice B is for extended duration greater than 6 months. So there's no right or wrong answer here, but please, everybody vote for either A or B. A, 6 months or less, and B, greater than 6 months. Oh, no, she's off the birth control pill. Yeah. But so by a margin of 3 to 1, we at NATF have voted for 6 months or less. So you see, there's a lot more research that has to be done. But obviously, if she lives to be 95 years old, we're not very enthusiastic about giving her another 72 years of anticoagulation for this, particularly when we have a way possibly to prevent, if this was all induced by estrogen, if she just stays off estrogen birth control pills, she might be okay. So the conclusions are that the rate of recurrent PE and DVT is high, that inflammation is a potent trigger of venous thromboembolism, that contrary to the current guidelines, that provoked VTE often, but not always, warrants consideration for extended duration anticoagulation, and that the safety of the novel oral anticoagulants compared to warfarin, with the NOACs being safer, and I showed you examples where of 2 of the NOACs where the rate of major bleeding complications was the same as low-dose aspirin. Their safety warrants and facilitates long-term anticoagulation as a practical therapeutic option. Thanks very much.